Welcome all to this month's segment of the TB Think Tank webinar series that takes place, of course, on a monthly basis. This session is titled A Closer Look at the Global TB Report. So I'd just like to briefly introduce our speakers for today before I hand over to them. We firstly have Dr. Gadegom Kondo, who is a medical doctor and a public health specialist who currently serves as the technical officer for TB at the World Health Organization country office. Her role primarily focuses on supporting the national TB program and key stakeholders in the TB response in generating evidence through research, development of normative guidance, and adaptation of global best practices to the local context. She has provided technical leadership in TB priority studies and periodic program reviews in several countries. She has extensive clinical and public health experience in the TB and HIV programs. Her experience over the years spans the public health sector and NGOs in both local and international settings. And our second speaker is Mathieu Bastard, who is a statistician in the TB Monitoring, Evaluation and Strategic Information Unit of the World Health Organization's Global TB Program, supporting the work on the TB burden estimation for the Global TB Report. Before joining World Health Organization in 2022, he worked for 12 years with Epicenter as well as Doctors Without Borders, where he was supporting operational research TB projects in Eastern Europe, Sub-Saharan Africa, and Asia. With that said, I will hand over to our speakers for today.
Thank you so much, Nolwazi. I will get us started. I'm going to just speak about some of the key highlights from the Global TB Report that was released late last year. And my colleague, Mathieu, would then take us through the behind the scenes on how the estimates are determined. So with that said, I will share my... Okay, let me just say share. Okay, I hope you can see my screen. You let me know if there are any issues. Okay, so just taking us a bit through the Global TB Report. So as colleagues may know, WHO releases each year a Global TB Report. The current Global TB Report 2023 was released late last year in November, and it's what will take us through out this year until we release a new one in around November this year. We've released many global TB reports. They date back, I think, to probably around 1995, if I'm not mistaken. Here, I've just displayed the ones from 2015 onwards, which is the period from which we transitioned to the end TB strategy. Just to note that the global TB reports provide a comprehensive and up-to-date assessment of the TB epidemic. They give us the progress on where we are globally in terms of prevention, diagnosis, treatment, disease, both at global level and regional level, but also at country levels. So, and of course, all this done in light or in context of the global TB commitments, strategies, and targets. Before I continue, just want to say accessing the Global TB Report can be done through our website. On our website, we have, you'll be able to download the PDF version, or you'll be able to access the web version, but also just to let colleagues know that we do have the report available on our apps, whether it's Apple Store or the Google Play Store. You will be able to download that, and you will also have access to global, regional, country level data, but also not just for this report, you're able to see the trends over the years. So it's a really great app to download to have information easily available for you for South Africa, but also to look at other countries. So let me start with a quick global overview. So coming out of this global TB report, just to note that TB is still one of the top infectious killers in the world. I think that is worth highlighting, that we still have a lot of work set out for us. We do see in the report some major recovery in the number of people diagnosed with TB and those that are treated in 22. And we just really see a good recovery from the impact of COVID. However, global TB targets have either still been on, have either been missed or remain off track. So we still have quite a bit of work to do in that regard. With regards to the burden of disease, in the report, we highlight that 10.6 million people fell ill with TB, 7.5 million were diagnosed, which leaves us with this gap of about 3.1 million who have either not been diagnosed, who have not been diagnosed or have not been officially reported to national authorities, whatever that may look like. And then of those 10.6 million people, about 55% are men, 38% are women, and 12% were children. I will touch a little bit on the South Africa data just for comparison towards the end, but also just to say that people living with HIV globally are accounted for 6.3% of this total. Of course, this is much higher in South Africa. Also, just to note that while I've highlighted that TB is one of the leading causes of death, with regards to people living with HIV, it is still a leading cause. And also what we've highlighted in the report is that it's a major cause of antimicrobial resistance related deaths. About about 500,000 of excess deaths have also been reported over the period of 2020 to 2022. This is because of the COVID-related disruptions. So that said, it's not all doom and gloom. We do have an increase or an improvement in the treatment success rate for people with DSTB. It's at about 88%. And for those with MDR or RRTB, it's sitting at about 63%. We still are facing quite a bit of a challenge with drug-resistant TB. It remains a major public health crisis. As you can see in the diagram, South Africa is among those that are contributing a significant amount. Also, just to highlight that in 2022, out of the 410,000 people that developed drug-resistant TB, MDR or RR, only about 175,000 were treated or were started on treatment. What that translates to is about 2 in 5 people with drug-resistant TB accessing treatment, which does pose quite a challenge and, of course, makes this a public health crisis. With regards to the trends in notifications of people with TB over the years, we do see this dip in notifications and around 2020, 2021. And this is, of course, attributed to the COVID-19 pandemic. So what looks as if we're reaching the 2025 milestone for our NTB strategy target is not quite that. We have seen this recovery, though, but just to say that over the years, we have seen this steady decline of notifications among people living with HIV, and that is, of course, attributed to the great progress that has also been made in the HIV programs. Like I highlighted, with regards to the targets that were set out in the UNHLM, the first UNHLM, so when we look at this 5-year period from 2018 to 2022, we actually did not achieve the targets that we set out to achieve. This we highlight in the report. And just to say that for TB treatment targets, we were at about 84%. That's, I think out of all the targets, the one that we've really performed the best in. But however, when you look at the targets around funding, the targets around TB preventive treatment and TB research, we still fell quite far short of what we hoped to achieve. I'm just going to touch on a few of the other areas that are covered in the report, starting with the universal health coverage, social determinants, and multi-sectoral action. So as colleagues may know, one of the targets for the NTB strategy is to have 0 patients and their families facing catastrophic costs due to TB. Globally, we are sitting at an estimated 50% of TB patients and their household facing catastrophic costs, and we define catastrophic costs as more than 20% of the annual household income being spent on TB. And of course, these costs are both direct medical and non-medical, as well as indirect costs such as income loss. In addition to that, we do also look at the 5 risk factors, or the top 5 risk factors for TB. And globally, undernutrition was by far leading, followed by HIV and alcohol use disorder. This picture looks a bit different for South Africa, of course, with HIV leading by far, followed by undernutrition and alcohol use disorder, and then smoking and diabetes. And of course, you know, WHO has been working with countries, especially high TB burden countries, to include accountability mechanisms in TB programming, as well as in engagement with civil society for TB program reviews and other engagements. So we have seen this also in South Africa through the multi-sectoral accountability framework for TB. Just going to touch on the uptake of diagnostics, new drugs, and regimens. So when we look at the WHO recommended rapid molecular tests being used as the initial diagnostic test, we find that only 47% of those that were newly diagnosed were diagnosed with a rapid molecular test as an initial test. This is an improvement from 2020, so from 33% to 38%, but we would really like to see this improve. By the end of 2022, we also had around 40 countries that had started to use the new 6-month BPAL regimen. Yeah, this was being used to treat people with MDR and pre-XDR TB. Also, just to highlight that with regards to the shorter regimens for TB preventive therapy, we had in 2022 around 0.6 million people in 74 countries. This was an increase from 52 countries and only 185,000 in 2021. So we've seen a marked increase with regards to the coverage of TB preventive treatment. On a more exciting side, with regards to research and innovation, in the report, it highlights the expansion of the diagnostic pipeline. So this is with regards to tests, products, or methods that are currently in development. So what we see in the pipeline is molecular tests for TB detection. We see the use of IGRAs. We see biomarker-based assays for detection of TB, CAD for TB screening, and also a new class of aerosol capture technologies for the detection of TB. So there's a lot happening in that space. We also see some new antigen-based skin tests that perform better than tuberculin skin test. And these had been evaluated by WHO in 2022. WHO had also convened a guideline development group to assess the use of targeted next generation sequencing. We had 16 vaccine candidates that were in clinical trials at various stages, and 4 were in phase 3, and we are all anticipating what will come out of that. And there were at least 29 clinical trials that were looking at drug regimens and different models of delivery. So there's a lot that's happening in that space. And just to say that we did not meet our end our UN high-level we did not meet our UN high-level meeting targets that we set, but with the new targets and with the new commitments that we've made, we really need to ramp up efforts in that regard. With my remaining time, I'm just going to touch on briefly on what the picture looks like for South Africa. So all of this is also in the Global TB report. Some of it is from various links in the Global TB report that you will find, but it just summarizes it nicely. So the 3 targets for our NTB strategy are a reduction in TB incidence, in TB deaths, and to have 0 catastrophic cost. So the 2020 milestone, the next one is 2025. So we're just going to focus on the 2020 milestone for this report. We had hoped to see a 20% reduction in TB incidence. South Africa achieved a 53% reduction. So this is really quite major. And in fact, this means that we have crossed our 2025 milestone for a reduction in TB incidence, which is set at 50%. With deaths, however, we are struggling quite a bit. The target that we had set for 2020 was 35%. We've only reached 17%. And really, when it comes to TB, it being a curable disease makes these deaths, I think, that much more painful, if I can say it in that way. And then for catastrophic costs, South Africa reported 56%, slightly higher than the global average. With regards to trends, this is pretty much looking like I think the global picture where we see this dip in incidence in around during the COVID period, and then we recover quite well from that. However, I'm not going to talk too much about the HIV negative mortality. I think Matteo might touch on it, but just to say that, we are seeing this sort of like upward trend in the Global TB report when it comes to HIV negative mortality. Just to talk a little bit about mortality, I want to say what this translates to. So we had 54,200 deaths in this Global TB report, and that translates to 1 person every 10 minutes. So probably by the time I'm done with my part of the presentation, we would have had 2 deaths. And when we look at it like that, and keeping in mind that TB is a curable disease, I think I would implore partners and everyone that's around the table when it comes to TB that this is something that we really need to make some concerted efforts on. Just looking briefly at the notifications and risk factors. With regards to the total cases notified in the report, we have 224,000 plus. And with regards to men, it's similar to the global picture at about 55%, but women, we have slightly more or a higher proportion at 38%. And for children, we have a much lower percentage than what we see globally at 7%. And I think it's not a surprise to anyone that we are actually missing quite a lot of children, and that's an area that we also need to work on. I've already touched on this, that with regards to the risk factors for South Africa, the picture is a bit flipped, where HIV is contributing much more than undernutrition, which contributes higher when you look at it globally. And also just to say that in the report for patients with a known HIV status who are HIV positive, we reported 54%. So we can see why that is a huge driver. Before I wrap up, just to touch on, I think, 2 more areas. With regards to TB prevention, we do see a decline in the people started on TB preventive treatment in 2022. So this is also an area that I'm hoping that we can scale up, especially with availability of 3HP in the country. As we know that we were not yet reporting on contacts that are aged 5 and over, but we will be reporting on those, I think, this year. So hopefully we'll be able to see that dark green picture start to increase with time. Yeah, just to also touch on a little bit on the treatment success, we're sitting at about 79% for those who are started on drug-susceptible TB treatment and 62% for those started on drug-resistant TB treatment. And with regards to the WHO rapid diagnostic test, we're using that test as an initial test for 74% of our patients, which is quite significant and much higher than what it looks like globally. However, the treatment success is falling far short of what we see in the global picture. So again, colleagues, I will highlight or emphasize that if we are really to end the global TB epidemic, if we're really to move towards ending the TB epidemic in South Africa, we really do need to start translating those commitments that we've made and really start in our own ways, whichever area that we are working in, working towards achieving some of those targets, and especially addressing the issue of deaths and continuing to decrease our TB incidence. That's it from my end. I will hand over to my colleague, Matteo.
Thank you very much, Dr. Nkateko, for this great overview of the global TB report. So I'm going to share my screen. I hope it's okay and that you can see it. So I'm going to give a brief overview of the methods used by WHO to estimate TB mortality and TB incidence. And basically see how all these numbers was derived and then presented into the global report. So as you know, the burden of TB disease is measured in terms of two main indicators, which are TB incidence, which is defined as the new episodes of TB that arise in the population over a given period of time, and in terms of TB mortality, which is the number of deaths caused by TB that arise in the population over a given period of time. And these two estimates are produced annually by WHO using information gathered through surveillance systems and specific studies. For example, the case notification that the country are reporting every year, some prevalence surveys that the country are implementing, or for example, for TB mortality, the number of deaths recorded in the civil registration and vital statistics systems at country level. So for this presentation, I will talk about two different periods of time, basically before COVID and after COVID, because as you will see, some of the methods were different depending on these two periods. So I'll start with the period from 2010 to 2019, which are the methods used before COVID, and present a bit how the methods and which methods were used to estimate TB incidence and mortality. So just before that, I always like to show this small graphic, which is showing what we are trying to estimate on the left, the incident TB cases, and on the right, the notify and initiating treatment patients. So as you can see, if we are trying to estimate incident TB cases, only a certain proportion of them will be diagnosed with TB. And then we are talking about underdiagnosis. And among these diagnosed, only a certain number of them will be notified and initiating treatments. And then we are talking about under notification. So all the work we are trying to do when we estimate the incident TB cases, starting from the notified and initiating treatment patients, are from the right to the left of this graph. So historically, 5 methods have been used to estimate TB incidence in the period 2010 to 2019. The first and the most widely used methods are using results from national TB prevalence surveys, combined with some hypotheses on the duration of the TB disease. And this was used in 28 countries. And many these countries were from Africa and Asian countries. And this represents about 39% of the total incident TB cases globally. Another method that was used to estimate incidence was to use a national TB prevalence surveys, which was combined with mathematical modeling. And this method was used for India and recently developed, as you have seen in the Global TB report this year. And this represented itself on about 27% of all the incident TB cases globally. The third method that is used is to use the case notification that are reported by the country, which combine with some expert opinion about the detection gaps and the trends in the notifications. And this is for countries where we don't really have a very good system in place at the national level. So we are trying to combine what the country is reporting in terms of notification and expert opinions from the epidemiology of TB in the country. And this was used for 39 countries. And this is representing about 6% of the incident TB cases globally. Then for a certain number of countries, and mainly the high-income countries, we are using the case notification data reported and a factor of adjustment to account for underreporting and underdiagnosis, and potentially also for overreporting and overdiagnosis. And this, as I said, is used for a big number of countries, mainly the high-income countries, and this accounted for about 11% of all incident TB cases worldwide. And finally, one of the last methods that were used to estimate TB incidence was to use inventory studies combined with some modeling called capture-recapture. And these inventory studies were implemented in several countries listed here. And the idea of this inventory studies is to try to estimate the underreporting of TB so that we can adjust the case notification using these estimates of underreporting to derive TB incidence. And this method was used in 8 countries, as I said, and it represented about 70% of all incident TB cases. So this is just a map, as you can see also in the global report, showing the different methods that were used for TB incidence. And as you can see, if we look at South Africa, the methods used for estimating TB incidence was based on the prevalence survey that was done in, I think, 2017, 2018. So this was the main source of deriving TB incidence in South Africa. So for TB mortality now, during this same period, 2010 to 2019, 2 methods have been used historically to estimate mortality. The first one and the most widely used is the using direct measurements of mortality from a vital registration system or mortality survey, either using data reported directly to WHO or using, for some countries, some results estimates and model done by the Institute of Health Metrics and Evaluation, called IHME. So this direct measurements was used for 124 countries, and this was used in most of the region, and you will see also except most of the African countries. And these countries, when we can't obtain good vital registration data from the countries, we are using what we call an indirect estimation of mortality, which is basically derived from the estimates of TB incidence and some hypotheses on the case fatality ratio derived from systematic reviews and meta-analysis of the literature. So we have several hypotheses on the case fatality ratio, which are stratified by TB treatment status, HIV status, and whether a patient were on IRT or not. And with this, we can basically apply incidence times case fatality ratio to derive TB mortality. And this is just a map to show the different estimates of TB mortality and how it was estimated in the different countries. So as I said, as you see in Africa, most of TB mortality was estimated using the indirect methods. And for South Africa, we're using the estimates derived by IHME. So now in the period 2020 to 2022, so as Dr. Nkateko said, and also seen in this graph, after several years of increase in TB notifications up to 2019, we have seen a big drop of about 18% in TB notification in 2020 due to the COVID disruptions, followed by a partial recovery in 2021 and another good recovery in 2022. So we needed to adjust our methods to account for this major disruption in the provision of an access to TB diagnostics and treatment services that have occurred during this period in the context of the COVID-19 pandemic. So working with the Imperial College in London, we have developed mathematical dynamic models to produce estimates of TB incidence and TB mortality in a subset of countries where we have seen a drop higher than 10% in TB notifications in 2020 as compared to 2019. And in countries where no or moderate COVID-19 disruption were noticed, we use the previous methods as I explained before. So of course, you can see additional details of this method in the technical appendix that is published on the website. So why would the reduce in notification affect the TB epidemiology? So the hypothesis is that if we have a reduced number of notifications, it means during COVID, means that we have fewer people diagnosed and initiated on TB treatment. So we have an increase in the burden of undetected and untreated TB. So this will, at the same time, meaning that we have more patients going untreated, which will increase the mortality, and we are also increasing the prevalence of infectious TB. So all the idea is to develop a mathematical model to account for all these of this dynamic, and at the same time also accounting for the fact that in some countries we have periods of restrictions and lockdown, which would have reduced the intensity of TB transmission. So when we try to model the impact of the disruption, we have thoughts of compartment models. I will not go into all the details of the mathematical model behind that, but just basically to show a graphic representation of the model from the infected. The people will go either to latent or slow disease progression, fast or slow disease progression, and then go into the state of active infectious disease. And then on certain proportion of them will go on treatment and recover, and another proportion of them might die. So we have tried to use the COVID-19 model the COVID-19 disruption, and mainly using the notifications from the active infectious disease states to the on-treatment. And this is where the reduction in notification and during COVID were accounted into the mathematical model to estimate incidence. And what we are trying to estimate from this mathematical model is really the part in red and the parameter lambda, which are representing the TB incidence. And the big assumption of that model, as I said before, is that a reduction in notifications are largely attributable to underdiagnosis. And then if we see a decrease in TB notification, this means that we will have an increase, a direct increase in mortality because more patients will get untreated, and lately an increase in incidence because more patients will be will not be diagnosed, and then this will become this will imply an increase in transmission of TB. So these models were used in I think about 50 countries overall. There's the countries you can see in red, in green in this map. So South Africa were not part of these countries, but you can see that globally there were a certain number of countries when we have seen a big drop in TB notification during COVID. And this is how, and this is where we have used mathematical models to estimate TB incidence. And with the same model, we are also able to estimate TB mortality, because with the same model, we can estimate both incidence and mortality. So TB mortality have been estimated using these mathematical models in the same subset of countries. So the methods that are presented here are the one that can be used to evaluate the progress towards the targets of the WHO and TB strategies and the UN SDGs for TB. Of course, the ideal is that the national TB programs should be able to measure the level and the time trends and incidence through well-performing TB surveillance system. But this is not always the case. So this is why we have to develop methods to estimate TB incidence. And as these programs were in some countries disrupted by COVID-19, we had also to develop new methods to account for these disruptions. Regarding TB mortality, ideally we want it to be measured by counting death in a national or sample vital registration system with high coverage, but also good quality of data based on international classification of disease standard. But as you have seen in this presentation, for some of the countries, we don't have enough good vital registration systems, so we are estimating TB mortality by indirect methods, or again, because of the COVID-19 disruption, we have to estimate TB mortality through mathematical modeling. So The WHO has also a global task force on TB and impact measurements, which are meeting regularly every 2 years, I guess, to discuss and review the different methods used to estimate TB incidence and mortality. And the last meeting had happened in 2022, and we are planning to have another meeting in this year to review and discuss again all the methods used to estimate TB incidence and TB mortality. So thanks again, and I'm happy to take questions.
Thank you so much to our speakers. We have a Q&A tab there at the top, so please do enter your comments or your questions that you may have for our speakers for today. Do you perhaps have any remarks while we're waiting for questions, Dr. Mkondo and Matthieu?
Yes, no, thanks, Nolwazi, and thanks to Matthieu for his presentation. One of the things I meant to say as I was presenting is that every time after the Global TB report is released, without fail, someone will either write to us or, ask, where do these estimates come from? How are they derived? There's always, we did our prevalence survey a long time ago. So, are these numbers still up to date? And I think Matthieu has, explained it quite aptly, how these estimates are derived, where estimates are used, and where our prevalence surveys come into play, but also that the data that we reported, even for South Africa, a lot of it is reported from the TB program. And so I hope that gives people quite a bit of insight. I don't know if Matthieu has anything to add to that. Thanks.
Thanks, Dr. Nkateko. No, I think you're right. I think this is important that people are understanding how these estimates are derived, because every year the countries are sending their notification, and then they are just waiting for the profile to be shown on the website. So it's very important, I think, that people are understanding how these numbers are derived, because it has some implications in terms of for the programs, but also in terms of the targets for the NTB strategy. So there is always a technical appendix that is also published along with the Global TB report. So I can understand that this appendix is somehow technical, but that's important. I think if anyone has questions for clarifications or more technical questions, that there is absolutely no problem to reach us for more deeper explanation on how these two indicators are derived. And I hope my presentation was a bit clear, although it's a bit difficult to give all this in only 15 minutes. But I'm happy to answer any questions.
Okay, thank you. And also, please be reminded, as mentioned, if you somehow come up with a question after our live session, you can email myself at ngosi@tbthinktank.org, and then we'll ensure that our speakers get back to you with an answer. So we have a question here. It says, I note that you said your model took into account the impact of lockdown on transmission. Given that there was decreased access to TB diagnoses and therefore fewer people getting diagnosed and put on treatment, how much do you think transmission could have positively benefited from lockdown?
Okay, so I guess it's a question for me. Thank you very much. So just to clarify first that, because I see the person is mentioning South Africa. So South Africa was not part of the countries that were using mathematical models for this exercise. So just first. And then thanks, yes, indeed. I have mentioned that the reduction in transmission due to lockdown was also accounted for the model. So we had to make some hypothesis on that for the model. So it has been said that during lockdowns, a reduction of 50% transmission was applied. And this is what we have used and the hypothesis and the inputs from the mathematical models. So there is two things. The lockdowns, of course, it reduces transmission because people are staying home or wearing masks. So all the restrictions that were put in place have also a role in the TB transmission. So we have assumed a 50% reduction for these periods. But at the same time, we have also this hypothesis of any miss cases or any reduction in TB notification is a cases that is not diagnosed. So we have taken together, we have seen this increase in TB incidence with a certain delay, because of course, if you look at the global map, you will see that incidence is not starting to increase in 2020, but only in 2021. So this decrease in 2020 is reflecting the reduction in TB transmission. And this is only a year after for living time for the transmission of TB that we can see this increase in TB incidence.
Thank you, Mathieu. We have a question here that says, how do you account for private sector data?
So yes, thanks. Yes, the graph I showed for the model was a bit simplified for the benefit of everyone, but if there was an important private sector in the country, we had separate compartments to account for the public and the private sector. So this was also accounted into the model. So yeah, if the country has a certain amount of if we have private data from the private sector, we may be able to account for that.
Thank you. The next one says, you model high declines in TB incidence in SA from 2015 to 2022. I assume that this is largely driven by ART uptake. To what extent have you addressed the poor ART outcomes where there's low retention at 12 months, high throughout in cyclical ART cascade? An example, patients falling off and joining at a high rate, implying poorer protective effect of ART.
So yes, I can answer a bit for the incidence trends, and maybe Dr. Nkateko, you can say a bit more about the IRT outcomes and intake in South Africa, if you have probably more insight into that. So yes, thanks. As you mentioned, we've seen a decrease in TB incidence in South Africa, and this is mainly driven by the prevalence survey that was done lately, and then for what's happening during the COVID, there was no more information, and we didn't see this drop in TB notification. We have just projected the trend that were previously estimated before 2019. And yes, as you mentioned, given we have seen also a decrease in TB HIV positive incidence, which is also reflecting in the numbers that we are presenting. And of course, the increasing ART uptake was also accounting, and this is just how it reflects into the incidence of TB now. Dr. Nkateko, would you like to add something about the country specific?
Yeah, also just to say that as data is reported for the global TB report from the TB program, we also have the HIV program that's reporting for the global AIDS report, and there is often, I guess, a link between the two or discussion between the two programs, and I guess maybe some of those effects we'll be able to see with time as we refine even, next prevalence survey, and as we refine our estimates. I think it's things that we would be able to probably pick up if that is the case, but maybe on a year to year, maybe those might be things that we don't see the shift as much as we would have liked to, if ever there would have been. So yeah, I guess with time we'll see what the impact of that is, but I hope that sort of answers the question.
Thank you, Dr. Mkondo. Our next question goes, one of the assumptions mentioned was that the drop in notifications was due to an increase in underdiagnosis, with reporting being unaffected. Would there not have been an effect on the reporting during COVID?
So I'm not sure I understand well the questions, but I have the feeling that you are talking about underreporting during COVID, which might also affect incidents, as I've shown in my first graph. So if that's the case, yes, I agree that during COVID we have the main hypothesis of the model is underdiagnosis. So any drop in notification is a missed case somehow. But of course, we can be also in the situation where during COVID and the disruption of the programs, we are facing some underreporting of the cases. The cases have been diagnosed, but they were not reported. So we have also, after discussions with the different countries where the model was used, we have also allowed for a certain underreporting rate during COVID, just to readjust and recalibrate the model. So this was also accounting in the mathematical models to estimate incidence and mortality.
Thank you for that one. We have a question. I'm not sure if perhaps you mentioned this, Dr. Mkondo. They ask, how often should we have national TB prevalence surveys for the incidence estimation to be up to date?
So I know that the recommendation, TB prevalence surveys are a costly exercise. Anyone who was a part of the last survey will know that. So they've been repeated in some countries after 5 years, in some after way more than that. Matteo, I don't know if there's a specific number that you do recommend, but I know that, between 5 years plus, basically, we can repeat the next survey.
Yeah, thanks. I think, yes, 5 would be a minimum, but I think more realistically, it would be probably something between 7, 10, maybe 8 years. And as soon as we have a new estimate coming from a prevalence survey, we are updating the results for TB incidence, and we're updating the whole trend for the profiles.
Thank you. We have a question here that says the routine HIV data does not report on the cyclical HIV care cascade. We look as though we are performing better than we are.
I'm not sure it's a question. I guess it's maybe more
comment.
of a comment, which, yeah, I guess that might be the case, but yeah.
Yeah, and maybe I can jump on this, and because I think that would be, I'm not sure who is in this webinar, but I think that would be interesting if we have some people in the country that know very well the program and how it works in the country, with maybe, I don't know, working for implementing partners or the reality in the country, and to try to understand a bit more, because this comment, as you can see, is probably reflecting that we are not capturing everything for the estimations. So that's true. And maybe, I don't know if you remember, but if you look at the profile for South Africa, interesting thing that we may notice is an increase in notifications in 2022, although we had several years of decline. So I would be very happy if we have some people that would like to have a separate conversation on the reality on the ground, whether it's through the HIV data or HIV care, or also on TB, to try to understand a bit more, especially what's happening in 2022 and why you are thinking that you look performing better than you are in reality. And maybe Dr. Nkateko, you may also add something on that.
No, definitely. I think it would be good to facilitate this discussion. And I think one of the things that we had discussed with the NTP, I'm by no means speaking on their behalf, but it's just to have a platform to just discuss the data that's going into and coming out of the Global TB report going forward, just so that we are taking, I guess, all factors into account. We might not be able to address everything, but I think we definitely need to start having or get these conversations going. So we'll definitely set something up to that effect. Thanks.
Thank you. And just a reminder that if you would like to be on this platform, or if there are any discussions, conversations you would like to have, you can email myself at ngosi@tbthinktank.org, or anyone else from the TB Think Tank Secretariat. I think this could be our last comment or question. Please still do keep them coming through. This one is a bit of a mouthful. It's a comment that starts, given that treatment is the most effective means of transmission, and we know that fewer people had access to treatment and few people were wearing masks at home in South Africa, one would think that transmission would have increased, not decreased, as assumed in the model. They note that you mentioned South Africa was not included in the modeling. And they ask, has there been any work to quantify if this assumption of reduced transmission is accurate?
So thanks for the comment. I agree it's difficult because, I mean, any country is unique somehow, and we may have some countries with severe restrictions and lockdown and people wearing masks, and other countries with less restrictions, and then it's a personal behavior of wearing mask or not wearing mask. So it's very difficult to quantify really at that time, to quantify what's the real reduction or not in transmission. And we had also to keep something not simple, but I would say something that is more generalizable overall to reproduce all these results. So if you're talking specifically of South Africa, indeed, this was not part of the model country. So this assumption is not really implied. But for the other countries, this assumption sounds relatively good. And we may have also, of course, additional papers and publications that are trying to assess this level of transmission during COVID. If there are any evidence to update these numbers, for sure we will use it and incorporate into the model to try to make the estimates more accurate. But thanks for the comment, because yes, I think it's an assumption and it's a model. So any models have some assumptions, and our assumptions are questionable. And we are making sure to try to use the latest evidence to adjust the model and make it more accurate. But it's part of the limitations as any model.
Thank you. We have just about 9 minutes to spare. I heard you touching on the limitations, Machu, and as well as Dr. Nkateko. Do you have perhaps any other comments to add yourselves before we close?
Maybe I'll get us going, and I don't know if Matteo will want to add, but I think one of the limitations or the challenges that I know is a work in progress for us in South Africa has just been the changes around the TB data, moving from one system to the other. And I know for Matteo and the colleagues on his end, we've had a lot of back and forth about the data. So and I know he also highlighted the importance of countries reporting good quality, more accurate data from their program. So I think that's an area that is definitely worth working on. And I know that the country is making a lot of effort in that regard. But yeah, hopefully as we improve in that, some of the other data will also look different. Matteo, I don't know if you want to add.
Thanks, Dr. Nkateko. Yes, so all the methods are present in general have limitation for sure, and I would say mainly though that's where we don't have more evidence. So thankfully in South Africa you had recent prevalence survey, so we were able to adjust TB incidents according to this level. So what would be important, thinking about the targets of the NTB strategy and the UN SDGs, is to think about how incidents will be estimated in the next milestone in 2025 and 2030, because we will need to have maybe, I don't know, an updated prevalence surveys or more, as Dr. Nkateko said, more reliable data, especially if you're trying to improve the systems and And we need to think ahead and see how we will be able to assess the trends and in South Africa, and also the relative to the targets. So I think there will be some discussions and thoughts around that for the coming years. And I will also be personally very interested in discussing more deeply the transition in systems, and also what does it mean in terms of data quality for the notifications. And because I'm still very curious about this increase in 2022, whether it's reflecting this transitioning system, or is it reflecting an increase in TB detection? I think it's still something we need to clarify. That's why I recall what I said before. I'm really interested to discuss more this particular thing, because I think it's important to see an increase in TB notification after so many years of decline, to try to justify it, because people can question that, and I think we will need also to give some clarification. And I think it's important thinking of the targets and the milestones coming in quite soon, actually. Thanks.
Thank you so much. I think we are now at the end of our session, as we do not have any more questions or comments. If you're in the session and you still have any questions or comments, as mentioned before, please do send them through to myself at ngosi@tbthinktank.org. As well, if you'd like to see yourself on this very same platform in the next coming month or weeks, please do email myself at the same email address, especially if you have themes or topics that you'd like to be explored, perhaps relating to this session. And with that, I'd like to thank our speakers for giving us their time and allowing us to meet on this platform. And I would like to also just wish everyone a productive week ahead and enjoy the rest of your Monday. I'm seeing one question. I think it's a comment. So I think this is just a comment. So before we close, this comment says, I think it might be a response to something that has been said. They said that we have increased TB testing and lab diagnosis in 2022. So I think perhaps, Machu, they are responding to something you had said. Thank you for that comment. And with that said, enjoy the rest of your day. Thank you.
Thanks, everyone. Bye.